Alright, high altitude medicine. Let's do a quick recap before we get started. So at sea level, we have pressures of 1 atmosphere, or 760 millimeters mercury. The higher up we go, that pressure is going to decrease. High altitude is kind of interesting in that you need to go up pretty far before the atmospheric pressure really changes. It's only half an atmosphere at 18,000 feet. The other interesting thing about high altitude medicine is that it's typically a more chronic, or at least a gradual onset, when compared to, say, diving emergencies. We're talking about hours to days with a lot of these illnesses. So, general rule for treating high altitude illness is 1, get them to a lower altitude, and 2, high flow oxygen. Some of these illnesses occur just from a lack of available O2. That's due to a mix of Dalton's law and Boyle's gas laws. Quite often these patients just need some time in high flow oxygen or some time at lower altitudes before they can return to activity. Before we get into specific diseases, let's talk a little bit more about hypoxia. So altitude illnesses usually occur when somebody goes up in elevation too fast or without proper time to acclimatize. Elevations of 6,500 to 8,000 feet are commonly where we start to see issues, but they can be higher or lower depending on the rate of climb. So climbing too fast, the body isn't ready for the lack of oxygen and tries to compensate, causing a state of mild respiratory alkalosis. The kidneys try and fix that by secreting bicarb out of the urine, and quite often this can cause a rebound metabolic acidosis. The other side effect is the lack of oxygen tends to make tissues leaky and increase capillary pressures. The mechanism isn't well understood, but it's these two facts that can cause our main altitude illnesses. So first up, we have HAPE, high altitude pulmonary edema. It's caused when we have climbers who climb rapidly and start developing hypoxia. Usually happens within the first 24 to 96 hours of climbing, and climbers who go up above 8,000 feet. So physiologically, it's kind of cool what's going on here. The alveoli are being hypooxygenated because there's just no O2 in the air for them to breathe. The problem is the brain hasn't worked this out yet, or hasn't worked out why there's no O2. So the brain looks at each individual alveoli and thinks, that one's not working. I'll pull the blood away from it. So we get this pulmonary vasoconstriction, and it creates a pulmonary shunt, pulling the blood away from an alveoli. But it doesn't just do this to one alveoli, it does it to all of them, because none of the alveoli are getting enough oxygen. So this increased pulmonary pressure ends up causing some pretty severe dyspnea and pulmonary edema. But the really cool part about this is just a few puffs from an oxygen tank and the pulmonary edema goes away instantly. Patients should still probably be carried back down the mountain, but at least they can breathe. The next condition is a bit of a combo: acute mountain illness and high altitude cerebral edema, or HACE. They're both neurological conditions and are 2 points along the same line of disease. So you're on your first mountain expedition. You're excited, you get to your first camp and you're getting ready to go. You and your climbing buddies decide to have a little bit of a party before you start. Maybe you have a few too much to drink. So you get up early the next morning and you start climbing. And after a few hours, you start to notice you had a headache, you feel a little fatigued, and maybe a little nauseated. You just chalk it up to a hangover. Wrong choice. Acute mountain sickness can present just like a hangover. Typically, it's categorized as a headache with one of fatigue, lightheadedness, anorexia, nausea, vomiting, disturbed sleep with frequent awakening, or a mild shortness of breath with exertion. Symptoms usually start within 6 to 12 hours, but can be as late as 24 or as early as 1 to 2 hours after ascent. Worse during the night, the symptoms typically resolve as long as the patient stays at that altitude for a little bit and allows some time to acclimatize, typically 24 hours. If the symptoms don't go away, or the patient tries to keep climbing through the symptoms, AMS can progress to cerebral edema. You'll start to see altered LOC, ataxia, and possible seizures. It's important to note some patients skip the AMS phase and go right to HACE. So at altitude, it's important to have a high index of suspicion for this. Treatment for all altitude emergencies is pretty straightforward. Get them off the mountain. As soon as they get back down to some normal air pressure, they should start to feel better. Extrication can be difficult though, so often these patients can have some bad deficits by the time they reach the bottom, and may take longer to recover. Some places will have portable hyperbaric chambers that can work on a mountainside. If the patient has had one high altitude illness, the chances of them developing another, should they try and go back up to altitude, will increase. Last point, we can give patients a drug called acetazolamide as a way to help prep for mountain climbing. It causes the body to excrete more bicarb, causing that metabolic acidosis, which causes the patient to hyperventilate to try and compensate and can speed up the acclimatization process.